Today we'll see this interesting case, and usually I'm not very keen to implant a PCIOL if the capsular support is not very good, but here it was possible for me to consider placing a capsular tension ring and see if this can work for this patient. So technically a posterior chamber IOL would be a preferred choice, and this is the patient and this is the fundus and this is the point where you can see that this crystalline lens is grossly not centered, and we can see a defect superiorly because the surgeon is sitting at 12 o'clock, and this is slightly superotemporal area, it's a left eye, and we can also appreciate that there is some amount of phacodonosis as well. And these kind of situation usually induce a minimal amount of cataract, but more prominently they induce a irregular kind of astigmatism, and which cannot be corrected with glasses. These patients are also prone to have secondary glaucoma, not only because of the trauma sustained which can damage the trabecular meshwork, but also the vitreous may have prolapsed into the anterior chamber and contributing pupillary block. So placing an incision at the most convenient position surgically at the 12 o'clock position, and this is a self-sealing incision, and at this moment it's very important to take care that none of the aqueous in the chamber leaks out, because once the chamber becomes shallow the vitreous will tend to prolapse out. Putting in intracameral lignocaine. She is an apprehensive lady, and that is why it shows in attempt to close the eye when she feels some surface disturbances. And the plan here is to attempt to place in a CTR, stabilize the crystalline lens, the bag, and then attempt to put in a posterior chamber IOL in the capsular bag. Usually once you deepen the chamber, the anterior subluxation or prolapse of the crystalline lens may be reduced. However, during the procedure it is very much possible that the amount of subluxation may keep on increasing as the remaining zonules are stressed during the procedure, and they may give way. So one has to always have a plan B in this situation, because if the capsular bag is grossly unstable, then one has to resort to some other method of fixing the IOL, and for me the preferred choice is an anterior chamber Kelman design IOL. Now because we can see the anterior chamber is repeatedly getting shallow, so one way of managing this could be that do some vitreous tap. So if the vitreous cavity is shrunken a little bit, it may aid in deepening your chamber. But this is again a very titrated step, because too much deepening will also cause the iris lens diaphragm to subluxate posteriorly, and that is also going to stress the zonules which are just hanging on. However, in this scenario I was unable to aspirate any vitreous, because apparently the patient is a young lady, and as a result the vitreous is not having fluid pockets which could be drained out. So now, hoping to complete our excess, it's an elastic capsule, difficult to tear with a forceps. A cystitome could have been a choice, but then repeated attempts give you a kind of feel that how much pressure may be required, and completing our excess is again tricky because the chamber shallows, the lens subluxation increases, and the movement of the lens also increases. Replenishing viscoelastic material so that the chamber is maintained deep. An elastic capsule means that one will have to put more stress on the zonules. So it's a very slow and gradual process, and I also want to just let the audience know that this is being recorded, or rather played, at a normal speed, and I have not edited any portion out, just to give a feel that what is the kind of time and effort needed to do these tricky cases. It's a sort of challenge for the surgeon acumen, and one can always take up these challenges keeping in mind that the patient has to be informed. A very controlled hydrodissection, and this is actually the viscoelastic gel which was introduced in the uh, subcapsular area so as to dissect the adhesion between the cortex and the lens capsule. Making a side port, I don't expect a very hard nucleus here, but still there would be something which would need some amount of echo power. Adding some more viscoelastic in the capsular bag to complete the hydrodissection. This is much more controlled compared to a fluid wave. Viscoelastic material is retained better, it can dissect or permeate with greater force. At the same point, you don't need much of volume. So hydrodissection, or rather viscodissection would be the right term, may be a preferred choice when you want a very controlled cleavation of the plane between the lens matter and the capsule. This creation of this space is important because you would like to introduce your CTR in the same space, and if you use a fluid, it may get dislodged and you may again end up putting your CTR in the lens matter, which would later on cause problems during cortical aspiration. However, if you have well defined your space between the capsule and the cortex, you may be saved from this technical problem later on. Now these CTR are made of PMMA and they are thin, so although the material is rigid, but invariably because of the thin caliber they become flexible. So it's a durable material and a very gradual entry into the capsular bag, and we can see the rhexis border is being stretched, although in any given situation a round circular opening will have a better support and will not tear easily, so a capsular rhexis would be a better choice. Any situation where the capsular margins are rhexis margins are ragged will simply rupture. Now we can see the other end of the CTR, and this seems so traumatic that the amount of luxation has increased. However, the zonules being elastic are slightly stretched, and in any case one has to check whether these zonules remain functional at the end of the surgery and the bag is well maintained or not. So at this moment it appears that things are better. Trying to rotate the nucleus or the lens matter, but it's too soft, so I gave it up and then deepening the anterior chamber using viscoelastic gel. This is 2% methyl cellulose. Now this capsular rhexis is very small, so at this moment, although phacoemulsification could have been done, but it would be better the preservation of the capsule that we can increase the size of the rhexis. So proceeding to increase the capsular rhexis. Problem with the capsular rhexis in these scenarios is that the chamber gets shallow, the lens prolapses severely into the anterior chamber, and this prolapse will cause the rhexis to run out. So it may be better if we can stabilize the crystalline lens with a CTR and then proceed for the capsular rhexis. Although the disturbance of the cortex makes the rhexis advancing edge visualization a little difficult, but when you put in viscoelastic, the things move in a fashion that if you have a keen eye, then you can judge the location of the advancing flap. If the cleavage plane is well defined between the cortex and the capsule, the stress on the zonules can be reduced, and so a hydrodissection may aid into this, and you may have a situation where your rest of the surgery doesn't increase stress on rest of the zonules. This is the moment of test. If the lens subluxation doesn't increase, then probably we would be able to finish our surgery. Patient has to be persuaded to keep the eye open as well as the other eye open, so that the Bell's phenomena is reduced and the eye is maintained in a straight gaze with stable. For me, it was a technical challenge if I could implant a PCIOL in this patient, although I also had a standby anterior chamber IOL in situation where we would have needed a vitrectomy. Using the chopper to keep the crystalline lens deep in its place, so that when entering for the phacoemulsification there is no collision between the phaco tip and the crystalline lens, and then starting the infusion and seeing if overlying cortex can be removed. It's a very delicate phacoemulsification where you very tentatively and with good judgment remove some amount of overlying cortex and make a groove and see how it behaves. Usually the trauma could not only cause subluxation, but remaining zonules which are apparently normal also may not be fully functional. So it has to be a slow motion phaco, and as we can witness, a part of the cortex and lens matter has been removed, pulling the lens matter from periphery into the center in the safe zone and then consuming it. Patience is the key, and repeatedly innovating your movements and improvising how to pull out this lens matter without putting too much stress on the zonules. Lifting the material using the side port instrument to aid into this movement. The side port instrument can also be used to stabilize the bag and the CTR, and it provides a pretty good support. As I can see, the subluxation has not increased in any way. Rather, I can appreciate the capsular bag has come into a better position compared to what we had started with. So manipulating the lens matter with a dialer is easier and more safe if you have a situation where the matter is stuck subincisional space, which is tricky for manipulating the tip and at the same time aspirating this matter, because then you have to reach deeper, which is close to the posterior capsule. Now when the lens matter is in front of the tip, it is easier to aspirate. This surgery is being done under augmented topical anesthesia, meaning that intracanal lignocaine has been instilled so as to anesthetize the iris and ciliary body, and at the same time surface anesthesia has been achieved by using 2% lignocaine jelly. Most of the nucleus material has been removed. It's not a very hard and firm form nucleus, but then what is remaining behind is the cortex and the capsular bag. Putting in viscoelastic gel to deepen the chamber and to realign the anatomy inside the eye, and then we'll proceed for removal of cortex using irrigation aspiration cannula. Timidly, I am trying to go underneath the capsular axis border and then trying to aspirate the anterior end of the lens fibers to engage them and then pull it to center. And as we can appreciate, some fibers may still be trapped between the capsule and the CTR, so they may not get peeled easily. But if we recall, we had actually put in a CTR in the space provided by our viscoelastic or viscodissection, so that we have some situation where the cortical fibers may not be engaged in that space. At any moment, presence of a very clear media or an area which has a very clear view may actually be a ominous sign, because that may be a position where vitreous has prolapsed and would have pushed away all the overlying cortex. So here we can see the CTR and the cortex trapped underneath the CTR. So one has to be a little patient and keep on tugging so that the cortical fibers can slip and can be aspirated. So a slight use of controlled pull and repeated attempt may let these fibers slide from underneath the CTR and be aspirated. If at any moment one suspects that there's vitreous, then one should hold aspiration and then deepen the chamber using viscoelastic and then pull out your irrigation aspiration cannula. And this will usually save you from further vitreous prolapse. Now, some amount of peripheral cortex is there, but then the central area is clear, so we can ignore that area so that we have actually a fruitful situation. So rather than going for that area where there's some peripheral cortex, we'll proceed for implanting the PCIOL. Leaving behind the peripheral cortex may actually cause a situation where you have later on a PCO formation, but that can be easily dealt using YAG laser capsulotomy. So that is not a detrimental issue on which we can take the risk of compromising the entire situation. Injecting a single piece hydrophobic monofocal IOL in the bag. The leading haptics goes underneath the capsular excess and the trailing haptic can be dialed. At the present scenario, there is some amount of conjunctival chemosis which might have occurred because of leaking fluid from the incision site. The conjunctiva can imbibe this fluid and cause chemosis, and this usually results into a little compromise in the view because the pooling of the fluid starts occurring, which can cause annoying reflexes. So the IOL goes into the bag and it can be pulled up so that it is properly aligned to the visual axis up to the satisfaction of the surgeon. We can also appreciate an area of iris damage. Rather, I would say that this must have been a combination of damage due to the iris prolapse, and this iris prolapse must have been because of the atony of the iris in that area where the sphincter tear must have occurred. That is the superiotemporal area. That is the area where you have the maximum zonular dehiscence. Injecting some pilocarpine. The pilocarpine will provide a meiosis, and this meiosis may be helpful here because of zonules are not in very strong position. So iris can cover that area and provide us with some support to the IOL to prevent its prolapse into the anterior chamber. So iris can be our savior or scaffold for the IOL to push it back into its place and keep it there. The pupil has constricted slightly, but that area where the sphincter damage can be expected is not responding very well. So here we have a situation where the IOL is nearly perfectly centered and the pupil is slightly dilated, but we'll see if we can pull the iris back towards the center, and at times this works. Using the side port to do the same, because there the approach would have been better because this is the subincisional area, difficult to reach. Getting some space and then proceeding to coax the rest of the iris tissue to come towards the center. so that we have a better centered and a round pupil. Here we have it. The IOL borders are well covered by the iris tissue and the pupil, and the IOL is centered. The visual axis is clear, we don't have any remaining cortex, and then rest of it is removing the remaining viscoelastic gel. Using BSS to flush out the viscoelastic gel rather than irrigation aspiration cannula, but then looking at everything being so stable, we could use irrigation aspiration cannula with low settings so as not to cause shallowing of the anterior chamber or to pull any vitreous strand. So slow but prolonged irrigation aspiration to wash the anterior chamber from viscoelastic. So we could safely implant a PCIOL in the correct desired anatomical position, and we could save ourselves from resorting to anterior chamber IOL. Taking enough time to remove the viscoelastic gel using a swab stick to seal the incision so that there is no leaking of the chamber when exiting out, and then forming the anterior chamber using BSS. This finishes the surgery, and this is the post-op picture at day 1, and we can see the cornea clear. The pupil is slightly dilated because of a mydriatic use, and this patient gained very good vision 6 by 9 unaided. Thank you.